I hear you.
I'm standing.
Okay, when doing extremity work, it's going to be tabletop, and why you notice a lot of the techs will do their extremities in the ER portable. You know, bringing them back over to the department, just do tabletop work. Okay, the common mistakes that you will make is when you set the patient down, you'll set them down like this. The tendency is you want to bring the hand in front of their body. Well, first of all, their hand is right over their lap. Okay, so that's what you do not want. Okay, so just get in the habit when doing hand wrist, turn them this way. You still have the shield in their lap. Okay, so have a patient, please.
I'm sorry.
I'm here.
Okay. You want to fry those eggs? Or with
Yeah, you can leave that off. No, I'm kidding.
Nope, I want to. Okay, now typically what you want to do is you want to bring the table that they're sitting in even to where their arm is. Okay? And as such then, if you can, then set your 40-inch SID. Alright? Because if you get in the habit of doing this, then whether you're doing hand, wrist, forearm, elbow, or whatever, it's really critical when doing the elbow. Because the shoulder and elbow must be on the same plane. Alright? But for the hand and wrist, I can put it a little lower, it's a little more comfortable. Okay? So, we're doing the 3 views of the hand. There's a small film in there in the left you want to see.
Yep.
Right.
There's a small one in here.
All right, one of both. All right. So what we want to do is we want to center at the third, and again, remember we count anatomical 1, 2, 3, 4, 5. Right. So we want to center at the third carpal metacarpal junction, or at the head of the third metacarpal, which is this big knuckle. Okay, because the base and head. All right. I'm going to borrow someone's marker. Okay. All right. Now, technically, you want to start marking on the outside edge. All right. So I'm doing a hand, and the fingers kind of spread out. You want to spread your fingers a little bit, and you want to center at the head of the third metacarpal, or the carpal metacarpal joint. Okay.
Basically, it's center tissue.
Big knuckle.
Well, essentially is the center of the hand. Just right there on the knuckle, which is the carpal metacarpal joint, or the head of the third metacarpal, which is that big knuckle. Okay. Now you don't want to leave the cone field open like that. All right. So what you do want is you want to include just past the finger and an inch or so past these little bony prominences here called the styloid processes. So we want to include the hand, the wrist, and an inch or so of the distal forearm. So we bring it in to the side, outside the fingers. Okay, yeah, don't get too cute with the cone, right? And then down. Now, obviously that's not, but I got too much forearm, so I'll just slide the hand down a little bit. You know, instead of putzing around, moving the cassette, and you want to make sure that you keep the body part symmetric. In other words, I don't want it diagonal on the cassette. I want the cone filled edges parallel to the edges of the. Go ahead. I know text don't do that.
I was just going to ask, what does it do to the
And
algorithm?
they're like, do it diagonally, or is that totally different?
Lateral foot's a little different.
Okay, never mind then.
Okay, and I can explain why once we get the feet, but right now.
Is it always a bad thing if we do it diagonally? Because
It can, why?
What does it do to the algorithm? Is
I know this
curious.
isn't hand or wrist, but I had a tech and we were trying to get from the knee all the way down to the
But
ankle.
that's not a hand. Okay, there's certain things we have to, like for an entire tib fib, which we'll get to in the spring, you have to cant it, and you also have to increase your SID.
So does it not mess it up if you do a diagonal, if you have to get that much on it?
Not typically.
Okay.
Okay, ideally you want the collimated borders parallel to your IR, like this. So your top border should be parallel to the top border, side borders parallel to the side borders, and obviously your bottom border parallel. And you want to be centered at the head. And when you start doing this, don't make those 1/16 of an inch positioning changes. Okay? Whether I'm centered here or there or there, it's not gonna matter, right? If you get a cooperative patient, you should be able to knock out a PA, oblique, and lateral hand in 5 minutes or less. You see?
My easiest tip is to have my, is to have the cassette, lift your hand up and turn your light on, please. Okay, line it up to the center. I don't know if he's already told you this. And now all you gotta do is tell your patient, I want you to put your knuckle right here, right in the middle where that X is. There you go, you got it.
Just like when you walk up to the, say, sitting yourself on that line. Same thing, have it set up and approximate it. You know, you don't want it over here. So again, just have it approximated, and if they put it there, that's fine.
So let me ask you this, why did Mr. Salzy, I've already told you this, why did he turn his patient to the table like this instead of having them sit facing it?
Right under there.
No fried eggs.
Okay? Right?
And we would never say that to our patients.
No. No, we said this way you will not be directly exposed in the gonadal region because it'll be up under there. This way to the side, plus this, remember, distance is our friend, and this way you're not directly exposing the patient's gonadal region. All right? And again, remember, before the patient comes in, but if you adjust the table to a comfortable height to them, then you have to readjust your SID. Okay? And we want it 40 inches to the tabletop, not the IR, because it'll be about ½ inch difference. All right? So that is the,
What is the table?
so that's the PA hand. All right? Now, when we're doing the oblique hands, if the fingers are involved, we want the fingers straight. Remember when we were talking about the distortion and size and shape distortion? And one of the things is, we saw the joints on the fingers, how when the fingers were not parallel to the IR, that the joints were not open. Right? So if the fingers are involved, we want the fingers parallel to the IR, which is simply you change your cassettes and you turn the hand up 45 degrees. If you can, spread the fingers, and the thumb comes down. Kind of keep the fingers straight and just spread them enough. Keep them 45 degrees. Right? And so it's not rotating. And again, if you can, just center it. And then once I do that, now I can cone in side to side a little more. I'll get to that. All right? Now, if the patient has tremors with their fingers or something, they have a hard time holding, if there is a finger step wedge, you can use that. All right? And you can just have them rest their thumbs and just rest their fingers and just kind of keep them straight. And that helps immobilize, and it also helps keep the fingers parallel. Okay? Now, if you get a case where someone has struck something, they're worried about a fracture down here, which you'll learn once we go over what's called a boxer's fracture for obvious reasons, then it's not that critical. And with the hand down flat, you can just have them just kind of bend their hand up and their fingers resting down. But that's only if the fingers are not a point of interest. So with that oblique, and again, you want to just kind of just slide that over. And again, you can make slight adjustments just by moving the cassette. You know, so, but again, you know, don't get wrapped up in the around the axle on, you know, I've got to center at the head of the third metacarpal. Okay? Book answer.
Where is the centering for a hand? Does anybody know?
They should, I just told you.
No, it's not. Third metacarpal phalangeal joint.
Right.
Right?
Third MCP. Okay? Get these small sponges over here.
What would be a disadvantage to using those sponges there?
Especially these.
Cooties, that's
Pretty
the
much.
number one answer.
Yeah.
That's
Yeah.
not the correct answer, because they're supposed to be radiolucent at the KVP that we utilize them at, so they shouldn't show up. But if we're off on our KVP, some of them are made for different, you know, energies. But what she said, it's really not cooties, but contamination, right?
Right.
Same thing. But yeah, how can we clean those? We can't really,
Right.
right?
Most of the ones that we should use have that plastic cutting room. Okay? Yeah, but you could either put them in the cassette bag, or have y'all been shown what a chuck is?
Could I put like a wash rag over one?
No,
Wash back, yeah, that will leave that texture.
Bubbly.
Because using low KV, it really will show the soft tissue detail, which can also include the towel or
As long as you don't have to see, show.
pillowcase or something.
But
Right.
the pillowcase, that's the same thing, can't stuff soak through a pillowcase.
Right.
It depends on,
So-
you know.
But a chuck is kind of like a dog training pad. It's most of them are blue in the hospital setting,
We do know what one of those is.
Yes, we do.
right? And so typically they're under the patient to absorb any leakage, right? So you could actually cover one of these with that, or inside the clear plastic cassette bag. Right.
Yeah, that's a good idea.
Okay. Now for the hand, you want it at 45 degrees. So if you're doing a straight finger, you could just hook the thumb on that side and keep the finger straight. And if you can, spread the fingers a little bit. But the step sponge would be more ideal for doing that than without. Okay. Now there's two ways of doing a lateral hand. The ideal way is called the splayed, and it's amazing how spastic people get when you ask them to do this. So even though you start off by saying, if you can, make an OK sign to show them, and just turn your hand down. But they just, they just get wrapped up. It's amazing. Right? So again, say just, if you can, just make an OK sign and turn your hand on the side. And now we're just going to spread your fingers apart. Okay, we don't want the fingers, we want them close but not actually touching. And if we can, we'll spread the fingers. And again, this is good for doing a general survey of the hand and the individual fingers. But if they order a lateral hand for a foreign body, it's only going to be a straight fingered lateral with the thumb down. It depends on where the foreign body is. If the foreign body is in the palm area, you're going to want to have them flex the hand like this, or extend the hand like this. And if it's in the posterior, you want to have them flex a little bit. Right? But for our purposes, we want the fingers splayed. That is ideal for our survey. And I'm going to center pretty much right there. And again, you want to include the entire fingers, the entire carpal bones, and 1 inch or so of the distal forearm. Okay? So that is the 3 primary views that we do for the hand series, the PA, the oblique, and the lateral. Okay, and you've all got your task analysis, and it's basically covering the same thing.
One trick that I do for my lateral hand, even lateral wrist, once I get it into the lateral position, before I go back to the control panel, I move it a little bit posteriorly, not that much, because by the time you walk around, they're automatically just going to get back into where you wanted them. So just sort of like your chest x-ray, when
Right.
you do the lateral and you move them anteriorly just a little bit.
Mm-hmm.
I just move it ever so slightly back, so by the time I get around the control panel, they're back into the perfect lateral.
Right. And then when we get to the wrist, then we'll talk about the difference between the lateral hand and the lateral wrist. And what the difference is?
Centering.
That about 3 to 5 degrees. Right? Right. Now, a lot of times they will order a finger. Okay? Now,